Good morning, everyone. Good morning. I think we're going to get started. So first, thank you all for being here for the final of our fellow Grand Rounds presentations. Thank you to all the fellows who've presented. It's been a really fabulous year of fellow Grand Rounds presentations. Thank you to those of you who take the time to be here and support our fellows. It means a lot to us. I have the pleasure of introducing Sam Burles, one of our NP fellows based here at Mass General. And Sam developed her interest in palliative care through her work with critically ill patients and burn trauma, medical, neurological, and cardiovascular ICUs. She also worked as a sexual assault nurse examiner. As a bedside nurse, she worked and provided primary palliative care to patients and families throughout the course of critical care admissions, and this led to her interest in further palliative care training. She completed her family nurse practitioner training at Oregon Health and Science University before moving to Boston for her subspecialty training here with us. Sam's academic interests are engagement through direct teaching to nurses and physicians and other advanced practice providers. Sam will be staying on to work with us on our inpatient consult service, and we're delighted to have her. Welcome, Sam.
Thank you all for coming. Can you hear me in the back? Okay. So as Kathleen said, I'm Samantha Burles. I'm one of the Nurse Practitioner Fellows this year. The title of my presentation for you today is Never Worry or Work Alone, How Nurses Improve Palliative Care for Patients, Families, and Clinicians. I have no disclosures to share with you. By the end of my presentation today, I hope that you'll be able to describe the evolving impact of nurses on end-of-life care throughout history, understand past and present efforts to provide palliative care education for nurses, and identify opportunities to increase nursing engagement in palliative care. I also have a few disclaimers. I was a nurse before I became a palliative care clinician, and now I'm a nurse and a palliative care clinician, and really in that order. My experiences as a bedside nurse really inform how I think about and provide palliative care for my patients. And I'll be expressing some opinions that are definitely my own. So if you have a different perspective, I'd love to talk about it with you. I really think that it's the diversity of thought and experience of our interdisciplinary teams that gives us a lot of power to impact our patients. And so I would love to be able to learn from your experiences too. I'd like to tell you a little bit about myself and how I ended up here talking to you today. As Kathleen mentioned, I've been an ICU nurse for a long time. I finished school in 2006, and before I started fellowship here, I worked in a burn ICU. I worked as a float nurse, taking care of patients in all of the adult ICUs throughout a 6-hospital system. And then I worked in a mixed medical and cardiovascular ICU. I provided a lot of end-of-life care in the ICU. And I always tried to provide those patients and families with the care that I would want for myself or for the people that I love. I always found that to be strangely juxtaposed with the very clear understanding that that's not what I would want for myself. I would never want to spend my last days in a hospital or in an ICU if I could avoid it. The palliative care teams in my hospitals didn't spend very much time in the ICU. And that meant that the care that we provided for critically ill and even dying patients was frequently aggressive, and it sometimes even felt futile. Our general practice really was to support our patients and their families by doing and doing and doing. A number of the patients that I took care of during my time as a bedside nurse really impacted me because I felt so acutely distressed by the care that I was obligated to provide as their bedside nurse. While I didn't have the tools and knowledge then that I do now, it was clear to me that there must be something more or something better that we could do for these patients and families who were facing such unimaginable suffering and uncertainty. I'd like to tell you about a few of them today. AV was a 21-year-old woman who was found down outside her apartment. She was in respiratory and cardiac arrest. There was an empty albuterol inhaler laying on the ground next to her. And her arrest hadn't been witnessed, so we didn't know how long her downtime was. She had a history of severe asthma. She had been admitted several times within the last year for exacerbation, so it was very poorly controlled. She also had a history of smoking meth, but as far as everyone knew, she had been clean since she got pregnant with her 18-month-old daughter. And unfortunately, her tox screen was positive for meth on admit. She was resuscitated, she was intubated and sedated. She was cooled, and unfortunately, when we rewarmed her, she didn't make any meaningful neurological recovery. Her parents and her daughter's father also struggled with substance use. And while she was in my ICU, her daughter was put into foster care. And she ended up being discharged from my ICU to an LTAC, completely unresponsive, with a PEG and a trach on a long-term vent. SA was a 64-year-old hemodialysis-dependent man who was admitted to my unit for hypertensive crisis. And he was actually doing really well. He'd stabilized. He was just waiting for a floor bed. While he was waiting for a bed, I had a chance to get to know him a bit. He told me that he had spent almost all of his adult life working as a tugboat captain. He worked 2 weeks on, 2 weeks off. He would go between Coeur d'Alene, Idaho, and Vancouver, Washington on the Snake and the Willamette Rivers. When he became dialysis dependent, it forced him into retirement because he couldn't be away for that long, obviously. He told me that he felt like that was kind of a death, like he had lost a big part of himself when that decision was, he almost felt like it had been made for him. But he also told me that he was grateful to be alive, and he was grateful that he still had some independence and was able to take care of himself. While he was waiting for a floor bed, he suddenly developed chest pain that radiated through to his back. He was hypotensive with a pulse deficit. And he was diagnosed with an ascending aortic dissection. So he was rushed to the OR. He had a devastating stroke there. It left him paralyzed on one side, aphasic, unable to swallow safely. He was incontinent, and he had a new seizure disorder. And this man who had been so grateful to still have some independence ended up being discharged to a SNF with a PEG, completely dependent for all care. MG was a 36-year-old woman who'd been in a house fire. She had mixed partial and full thickness burns to more than 90% of her body, and she also had a severe inhalation injury. Based on all morbidity and probability data, and also just based on our experience, we knew when she was admitted that her burns were probably not survivable. The fire department found her laying on top of her 8-year-old son. She was a single mom. They thought that she was probably trying to protect him. He was also admitted to my burn unit with burns that were less extensive than hers. So she was intubated, sedated. She was very difficult to ventilate because of her inhalation injury. She was requiring high-frequency percussive ventilation with a VDR. She had escharotomies or fasciotomies to all of her extremities in her chest. She was on CRRT. She was on multiple pressors. She went to the OR more times than I could count. She had extensive debridements. She had many excision and grafting surgeries. She was also getting wound care twice a day. That took several hours and was plainly causing her agony in spite of our best efforts to keep her comfortable. She died in my ICU of DIC after about 4 weeks. Her son was in my ICU for about 5 months, and I took care of him a lot of the time when I was working. And he would talk about her a lot. Most of the time, he would just tell me how much he missed her, or he would recall things that they had done together. But he also, a couple of times, would ask questions about her injuries and how much she hurt before she died. So, while I'll always wonder if these cases and others similar to them might have been handled differently, that's not why I'm telling you about them today. I'm sharing them with you just as a reminder that they're not unique to me, and that nurses everywhere are experiencing things like this on a daily basis. This isn't a new problem, and it's not unique to modern nursing. So I want to tell you a little bit about the history of nursing as it relates to palliative care. And I'm going to go back to Nursing 101, nursing theory. The word nurse comes from the feminine Latin nutritia or nutris, excuse me, both meaning to nourish. Nutrice entered the common vernacular in 12th century France and referred to wet nurses who were providing care for infants. It really wasn't until the 1580s that the English word nurse was first used to describe women who were caring for ill family members in the home. Intimate care of the sick and dying was really thought to be so distasteful at that point that nurses outside the home were almost entirely prostitutes. This gives you some historical context on the questionable costumes you've probably seen. Clearly the landscape has changed, right? So nurses are now highly trained professionals whose clinical work has become more and more skilled as technology advances. As much as nursing practice has changed, I think it's really important to reflect back on where we came from. Just to understand that nursing really has its roots in the care of the suffering and dying. And I would actually go as far as to say that palliative care has its roots in nursing. So how did we get from there to here? There are many strong personalities, strong nurses who have contributed to the growth of professional nursing and palliative care. And I'm guessing that even some of my non-nursing colleagues are familiar with some of the people that I'm going to tell you about. So this is Florence Nightingale. She laid some of the most important groundwork for nursing and palliative care. She was a well-bred young English woman whose decision to become a nurse really defied all social conventions of her time. She developed her skills and ideas while caring for wounded and dying soldiers during the Crimean War in the 1850s. She believed that well-educated women could use scientific principles to dramatically improve the care of the sick and dying. She was also something of an early feminist. She saw nursing as an opportunity for women to exercise their social and intellectual freedoms in a time when they really had very few professional opportunities. She went on to be an educator, and the nurses who trained under her learned very early on that they needed to provide equitable care to their patients, regardless of their race, ethnicity, or religion. In her 1859 Notes on Nursing, What It Is and What It Is Not, she observed that suffering extended far beyond the physical effects of illness. This acknowledgement that the body isn't the only cause of suffering is essentially an early description of total pain. And she was talking about this long before that concept was understood or had been given a name. She also wrote that nursing can relieve suffering without necessarily treating illness or disease, which is basically palliative care in a nutshell, well over 100 years before it was an established specialty. This is Virginia Henderson. She was a public health nurse and a nurse theorist who was probably best known for her nursing need theory, which really focused on increasing patient autonomy in basic human needs in order to speed healing. She believed that the mind and the body are interrelated and inseparable, and that all nursing care should be understood within the context of that connection. She was also the first to state that care of the dying is a primary nursing role. She was famously quoted in 1955 as saying that nurses assist the individual, sick or well, in the performance of those activities contributing to health or to its recovery, or to a peaceful death, that they would perform unaided if they had the necessary strength, will, or knowledge. So Virginia was an American contemporary of Dame Cicely Saunders. She founded the modern hospice movement and championed the practices that Balfour Mount came to call palliative care in the 1970s. And you might be saying to yourself, wasn't she a physician? She actually trained and worked as a nurse during the war, during World War II. And then in the years after the war, she trained and worked as a social worker. And it was only after that that she went on to become a physician. So she was really very close to being a one-woman palliative care team. She's an impressive woman. She had closely observed the dying throughout her nursing, social work, and medical careers, and she came to advocate for interdisciplinary teams really as the only way to treat what she called total pain. She really put a finer point on Florence Nightingale's idea, defining it as the physical, psychological, social, spiritual, and practical struggles experienced during serious illness and dying. So these groundbreaking nurses and many others paved the way for modern professional nursing and for palliative care. And their works and theories continue to impact the care that we provide today. The alignment between nursing and palliative care can be seen in the work that nurses continue to do on a day-to-day basis, and I'd like to give you some examples of that. Nurses provide presence and comfort to patients and families during times of serious illness and uncertainty. They assess and manage symptoms using existing medical orders, and when a patient's condition changes, it's often nurses who are requesting updated orders in order to better meet the patient's needs. They're constantly communicating with providers, with patients, with families about illness, treatments, symptoms, hopes, worries, supports. They weigh patient hopes and worries with the reality of what's possible. And I would also say that at the same time, they're weighing their own hopes and worries with what they perceive to be possible for the patient. They're constantly building rapport to provide individualized patient care that's consistent with patient preferences and goals. And they're thinking about the big picture. Does this patient have the supports that they need to get through bone marrow transplant? Will they be able to take care of themselves once they get home? What's their prognosis now that they're on third-line treatment? Nurses are constantly translating huge amounts of complex medical information into language that patients and families understand. They're also talking with providers when they're worried that care might not be aligned with patient goals. And I will just say that even in the most collegial settings, these conversations can feel pretty risky for nurses because they can strain relationships and cause friction, and that's persistent. Our nurses are doing all of these things every day with a lot of grace, while they're also working to manage the ever-increasing technical and tasky aspects of their jobs. I'd just like to point out that both of these last two slides, this long list, this could just as easily be titled Things That Palliative Care Clinicians Do Every Day. While our workflows, our perspectives, and our responsibilities are different, we're thinking about a lot of the same things, and we're asking similar questions. And most nurses are doing this work really without much formal training. George Dickinson is a sociologist who's done a lot of research on end-of-life teaching in nursing and medical schools. In 2007, he surveyed all of the American baccalaureate nursing programs. He got responses from somewhere north of 71% of them, so I think that his findings were very representative of what was going on in the United States at that time. And what he found was that, excuse me, most programs included less than 15 hours of end-of-life content, and that's in total across 4 years. Really, that number was actually probably slightly skewed up by some programs at UCSF, Rochester, and Columbia that had more robust curriculum. In 2008, the American Academy of Colleges of Nursing, which is the accrediting body for American nursing schools, announced that baccalaureate nursing programs had to include end-of-life and palliative care content, but they didn't specify what that needed to look like. So now, fast forward to 2016. AACN published new guidelines that included curriculum recommendations for end-of-life and palliative care content. In that same year, Farrell and her colleagues noted that while textbook content in those areas had increased by 16% since the year 2000, time constraints and faculty comfort continued to limit teaching of that content. I wasn't able to find any updated information on these figures in the 3-year interval. My hope is that that content is starting to diffuse into the education that nurses are getting in American nursing schools. Really, the takeaway here is that nurses are doing primary palliative care work every day with little to no formal training. It's largely learned on the job because nurses are thrown into these situations every day and they really just have to figure out how to navigate them in real time. In her grand rounds in May, my colleague Kate Shaka spoke to the moral and ethical distress that this kind of patient care can cause for frontline staff. It's very real, and I would say it's also very widespread. I'm thinking that you would probably all agree that pretty much everyone who takes care of patients has experienced this to one degree or another. I have wondered if nurses and physicians sometimes experience it differently. Perhaps just given that nurses spend more face-to-face time with a smaller number of patients than their physician counterparts. Maybe these interpersonal relationships can impact experiences of moral and ethical distress. And as it turns out, the data does support this. So in 2009, Epstein and Herrick described what they called a crescendo effect, where each experience of moral or ethical distress leaves what they call a moral residue, which essentially becomes a new set point for future experiences of distress. And it leads to an increase in overall distress over time. This effect has been studied in nurses and physicians, and higher levels of distress were found in nurses. Epstein and Herrick also mentioned that the clarity with which nurses can recall situations from years ago speaks to the power of the crescendo effect. The intensity of reactions that nurses like me continue to feel when recounting situations like the case studies that I shared with you used to be attributed to over-emotionalism in nurses. Really, these responses are better understood as a psychological response to repeated threats to moral and ethical integrity. And I've seen this play out again and again throughout my nursing career. I continue to see it here at MGH. There's a lot in the literature about factors contributing to higher levels of distress among nurses. A number of studies have suggested that the hierarchical relationship between nurses and physicians can intensify nursing distress due to differing philosophical approaches to healthcare delivery. And this may be a little reductive, but one of the examples that was given in the literature is that physicians tend to follow the traditional medical model, which is focused on diagnosis and treatment of illness, whereas nurses take a holistic approach to disease, really viewing it more within the context of what a patient can and cannot do for themselves. Poorly functioning multidisciplinary teams can also intensify nursing distress. Let me just give you some examples. Nurses often don't know what's being communicated between the various teams taking care of their patients. This can be perceived as a lack of engagement with their concerns because they don't know what's being discussed. They don't know that their concerns are actually being discussed amongst the providers caring for their patients. Different team members may tell different things to patients and families. This can cause confusion and sometimes even distrust among the patients and family members, and it also increases nursing distress. And nurses can sometimes feel that the insights that they've gathered through extensive contact with patients and families are undervalued or ignored. As caregivers who provide care ordered by others, nurses may feel responsibility without authority when they believe that they know the right course of action, but institutional or cultural constraints prevent them from enacting it. The extensive contact that nurses have with patients can in and of itself actually lead to more nursing distress. As they spend more time with patients, they may start to develop personal relationships and even a sense of personal responsibility for the well-being of a patient and for the care that they're receiving. And sometimes this even includes the care that they're not directly providing. There's a lot in the literature about one of the greatest contributors to moral and ethical distress being the perception by nurses that they're providing care that's overly aggressive, futile, or even harmful for patients. Despite these high levels of distress, nurses are doing really great primary palliative care work. A 2009 randomized controlled trial out of Dartmouth-Hitchcock found that nurse-led palliative care interventions were responsible for improvements in quality of life and mood for patients with advanced cancer. One 2015 study found that nurses increased saturation of palliative care by advocating for their patients in order to overcome barriers to palliative care consultation. Some examples of those barriers include things like provider misunderstandings or opinions on when palliative care is appropriate, cultural and communication issues that might be institution or unit specific, and also family misunderstandings about what palliative care is and what the intentions of palliative care clinicians might be. A 2016 systematic review that included 124 randomized controlled trials on specific populations and interventions appropriate for palliative care found that nursing involvement in palliative care led to statistically significant improvements in communication, care planning, psychosocial health, and patient and caregiver experience. In 2016, it was reported that a pilot program that embedded a palliative care specially trained registered nurse in a big emergency room in Jacksonville, Florida, had prevented unnecessary hospital admissions by addressing goals of care to identify patients appropriate for hospice prior to their hospital admission from the ED. And over the course of 1 year, ED to hospice admissions in this hospital quadrupled. And they also saw a commensurate decrease in ED to hospital admissions. It's interesting to note that they also found that patient and family satisfaction was improved by this intervention. So these are just a few of the examples that I found in my literature review. I think that we're all aware that the need for palliative care outstrips the supply. A 2010 American Academy of Hospice and Palliative Medicine task force found that there was a shortage of as many as 7,500 of hospice and palliative medicine physician full-time equivalents. A 2018 study by the same first author modeled the need for hospice and palliative medicine physician supply through the year 2040. What he was really trying to do was estimate whether current fellowship positions were adequate to meet the growing needs of this population. And what he found was that fellowships were currently graduating about 325 hospice and palliative medicine physicians every year. And in order to meet the needs that he projected for 2040, we would have to increase that number to 500 to 600 graduates annually. So we're continuing to run at a deficit, and it's growing. I will also just say that both of these studies suggested that training nurses, nurse practitioners, physician assistants, and other non-physician interdisciplinary team members would help to reduce physician workload and shortage and better meet our patients' needs. In 2017, the American Nursing Association and the Hospice and Palliative Nursing Association published a report called Call for Action: Nurses Lead and Transform Palliative Care. In it, they concluded that seriously ill and injured patients, families, and communities should all receive quality palliative care across settings. And they stated that this could really only be achieved through the delivery of primary palliative care by every nurse, regardless of their practice setting. Among their recommendations to support this growth were the widespread adoption of End-of-Life Nursing Education Consortium, or LNEC courses, at every level of practice, increased palliative care content in nursing pre-licensure exams, and then they also suggested that palliative care be included in requirements for continuing education for relicensure. They suggested funding, developing, and evaluating innovative palliative care models to address workforce shortages and the needs of underserved populations. Conducting intervention studies to alleviate compassion fatigue and moral distress to maintain the health of the workforce. Supporting funding and development of palliative care resources for low-resource communities, and promoting equitable reimbursement by all payers for registered nurses and APRNs providing hospice and palliative care services. So all of the key stakeholder professional organizations are represented here. We have the American Academy of Hospice and Palliative Medicine, the American Nursing Association, the Hospice and Palliative Nursing Association. They've all made very strong statements regarding the need for increased nursing engagement in palliative care. So how can we think about operationalizing this in our day-to-day practice? A lot of you are probably familiar with Dr. Atul Gawande. He's a general and endocrine surgeon at Brigham and Women's, and he has special interests in public health, quality improvement, and palliative care. My introduction to his work was through his 2012 TED Talk titled How Do We Heal Medicine? He's also written extensively about medicine at end of life. You may have heard of his book, Being Mortal, Medicine and What Happens at the End. And he's also written a lot of columns for Slate and The New Yorker. In this TED Talk, he discusses the coevolution of medicine and technology, which has led to more specialized and siloed care. He talks about how these days, every physician, even primary care providers, are specialists. And they're almost myopically focused on their own little organ system or discipline. The result has generally been worse care and higher costs. So he suggests that instead of cowboys, what we really need are more pit crews. These would be teams of people with the ability to recognize not just successes, but even more importantly, failures, to understand the causes of those failures, to devise solutions to them, and to disseminate them widely. These pit crews allow our systems to work more efficiently, and they lead to better care at lower costs. I should acknowledge a few things. Obviously, palliative care is a specialty. While we most certainly have our own cowboys, I'd like to believe that palliative care providers tend to think a little more globally about our patients' needs. The nature of our work really requires us to look at the big picture to help patients live as well as they can for as long as they can within the context of what's important to them. Also, lower costs are great, but really for the purposes of this discussion, I'm more interested in better care, better palliative care for our patients. So in his TED Talk, when Dr. Gawande was talking about cowboys and pit crews, he was specifically talking about physicians. I'd like to suggest that his idea is really generalizable to everyone who's involved in patient care. Nurses are the largest single category of employees in healthcare, and they're perfectly positioned to be the biggest pit crews in hospitals and the medical system as a whole. Because of the overlap in nursing and palliative care philosophies, really the synergy between nursing and palliative care, nursing pit crews can make this work more efficient, more effective, and more satisfying for everyone involved. MGH and the other partners institutions have, I would say, very well staffed and supported palliative care teams when compared to many, maybe most, hospital systems across the country. We're ahead of the rest of the palliative care pack in many ways. And we're there because we have a staff and leadership full of visionaries who are really striving to keep innovations in palliative care moving forward. We're also fortunate to have executive leadership who support these visionaries and have really supported our division as a whole. I shared with you the ANA and the HPNA's suggestions for changes to the larger healthcare system that can positively impact the engagement of nurses in primary palliative care across care settings. Through our engagement with professional organizations, colleagues at institutions across town and across the country, and through professional and political engagement, we can support the broad systematic changes that they recommended. But I think there's also a lot that we can do here at home. Being ahead of the pack doesn't mean that we don't have room to improve. And I would suggest that really broadening support for our nursing pit crews should be one of our highest priorities for improvement. Evolving our culture to better support nurses could serve as a model for many other healthcare systems and hospitals with much less developed palliative care programs. So what are some of the things that we can do here in our own not so little corner of the palliative care world? I think that a big start would be making daily direct communication with nurses one of our priorities. We should be asking for their input, clarifying their opinions on patient needs, explaining the rationale for the recommendations that we're making, sharing the content of provider-level discussions that they haven't been involved in, and also offering our support. It should be our standard of care to talk with nurses directly every day that we're providing care for a patient. Whether that's face-to-face, by phone, or texting them on their Volt, we should really be having those communications directly with the nurse rather than just assuming that they're reading our notes and understanding some of the things that we don't necessarily directly communicate in our notes. I know that sometimes it seems like we're so busy that we don't have another minute in the day for anything more or anything extra. And I would really just suggest that this is not extra. This should just be considered necessary. And I'll acknowledge that I'm not perfect at this, but I'm continuing to work on it every day. We can debrief more often and earlier in cases that are causing nursing and team distress. My wise and kind teachers here in fellowship have told me that I should never be worrying alone. I've observed many times during the course of this year that our nurses are worrying alone. I've been to multiple debriefs to support teams and nurses who are struggling with challenging cases. These meetings are often best attended by nursing staff who will come in unpaid on their days off to attend and participate. I think that really just speaks to their commitment to their work, to their units, and to their patients. Sometimes these meetings happen after patients die. Sometimes they happen after a significant event. I would say that in my experience, they could always have happened sooner to better manage nursing distress. If we're having daily communications with every member of our team, including nursing staff, no one is worrying alone. And we're really more likely to have our finger on the pulse of these situations so that we can provide early support and maybe even prevent some of this distress. Members of the palliative care team here at MGH have continued to offer unit-based training and palliative care content that's of specific interest to those units. The Continuum Project is training folks in many disciplines, including nursing, about serious illness conversation. These are great starts. I think that we should also be considering how the division as a whole can broaden educational offerings for our frontline nursing staff to ensure that they're prepared and comfortable in providing primary palliative care. There's this idea that we don't just palliate our patients and their families, but that we also palliate their primary teams and help them hold some of the distress in these situations. I think one of the ways that we can do this most effectively to support our nurses is by modeling and supporting a culture in which nurses can freely express their opinions and concerns and really feel that they're being heard and are valued. When our nurses display an interest or an aptitude in palliative care, we should really get behind them and support them and fund their continuing education, whether that's through conferences, LNEC, PSEP, or other offerings. We can also ensure that we're supporting nursing scholarship at every educational level by always being open to formal or informal opportunities to provide education and being willing to host learners who are interested in the work that we do. So just to summarize, palliative care is a relatively young specialty, but nurses have been developing and nurturing its principles and practices for hundreds of years, and they continue to impact its future. We all know that there aren't enough palliative care clinicians to meet the ever-increasing needs of our aging and ailing population. Despite this supply-demand mismatch, nurses continue to be undereducated and underutilized in providing primary palliative care. Really, a preponderance of evidence supports the positive impact that nurses have on palliative care for patients and for families. And it also suggests that increasing the number of nurses practicing primary palliative care to the extent allowed by their license improves quality of life and satisfaction for palliative care specialists. Changes in the national healthcare and educational systems, combined with local shifts in culture and practice, are necessary to broaden the use of primary palliative care skills by nurses at every level of practice. Our association with the Harvard Center for Palliative Care makes us leaders in this field. Whether you're a nurse, a physician, a pharmacist, a social worker, a chaplain, really, whatever your discipline, and whether you're planning on working at MGH for the rest of your career or, like most of my co-fellows, are going to be leaving in a couple of days to practice much farther afield, you're uniquely positioned to really impact the direction of nursing in palliative care. Other organizations are looking to us to set the stage for the future. And by supporting large systematic changes while also working on local culture change, we can continue to positively shape the landscape of palliative care for years to come. Increasing nursing engagement is really the key to broaden the diffusion of primary palliative care that will continually improve experiences and outcomes for patients, their families, and for our interdisciplinary teams. I want to just take this opportunity to thank all of the people who have supported my growth in education throughout the course of this year. To Simone Rinaldi, Kathleen Doyle, and Jane DeLima Thomas, I'd say you're really a perfect trifecta of brilliant and strong leaders, and you're also some of the kindest people that I know, and I'm grateful for your support. To my mentor, Allie Rhodes Kavanaugh, who always seems to know what I need before I do and has an elegant solution to every problem. To every member of our inpatient, outpatient, and home-based palliative care teams, and also to all of the teams who have hosted me on elective, thank you so much for your time. You've taught me a lot even when you didn't know you were teaching me. To Jim Fitzgerald, Gina McDonough, and Gail Chin, they're the administrative staff who keep the fellows on track and on schedule, even though it can be like herding kittens, they always do it with a smile. And to my co-fellows, it's a long list, obviously. I would say each of you are exceptional in your own way, and I'm really fortunate to call you my colleagues and my friends. And last but not least, to my husband, Jeff, who didn't hesitate to pick up and move all the way across the country so that I could chase this dream, and also to my son, Finn, who makes every challenge worth the effort. So I think we have some time for questions now. I'm happy to answer them here, and you're also welcome to email me if you have questions or comments. Thank you so much for your time.
Thank you so much, Sam, for a really thoughtful presentation. It was really wonderful. I want to put it out. Is there a question?
Thank you, Sam. Mine is not a question as much as a comment. I'm a social worker with the Palliative Care Service, and I always really feel like the bedside nurse is part of the palliative care team. And I think that's actually we need to see them. And part of when I'm teaching learners is to kind of emphasize that, before you even go see a patient, you talk to the nurse, because he or she may know something 5 minutes before you enter that room. They may impact your communication. And then also I was thinking, this happened a long time ago, where a nurse and I were taking care of a patient together who was dying, and she was with the patient all day. I came in and out, and this is an all day kind of thing that occurred, and finally the patient died. And then I saw her go to the nurse's station, and they were like, okay, here's your next admission. And I'm thinking, I can go to my team and kind of debrief and reflect. And this particular nurse didn't even have that opportunity. And then just hearing you speak made me also think the nurse is also the person who prepares the body to go downstairs. The nurse often accompanies that body downstairs. So, on some level, the nurse is with the patient at the beginning of when they start actually dying, throughout the entire process, and then kind of taking them downstairs and then exits by themselves. So I do think I just want to emphasize the importance of the bedside nurse and how I truly believe that our role as a palliative care clinicians is to always kind of see that nurse in that light. So anyway, thank you for providing that. It's great.
Thank you for sharing that.
Other questions or comments? I sort of had more of a comment, which is that Simone and Jane and Barbara and I and the rest of the leadership and the fellowship really believe in interprofessional education. And something I think we saw this year in particular, and I don't think your physician fellows would mind me sharing this, is when they checked out, every one of them talked about how they had no idea what it would be like to be in an interprofessional fellowship, because in most of medicine, people train in silos. And here they all come and learn together. And to every single physician fellow said what a benefit it was to them, how it's changed their practice, how much they've learned from the social workers and the fellowship and the pharmacists and the nurse practitioners. And I think that was music to our ears, because that's what we aim for. So thank you. You've already been teaching your co-fellows this entire year.
They've been teaching us too.
I want to see if there are any questions that Dana Farber care to mention. No, any other questions? Oh, got one up here.
Good morning. Thank you for your talk. I have a question. I'm here as a spiritual care provider, but I have a question more broadly for all of us. I'm wondering if you have thoughts on how this shifts when we're talking about outpatient or home-based care.
I think that a lot of the same concepts can be used. Really, a lot of the, if you look back to the ANA and the HPNA's call for action, a lot of the recommendations that they have for improving palliative care talk about making changes across care settings. They really are talking about across the healthcare system. I would say I have spent very little time working in the outpatient setting. I've spent my entire career working as a hospital, and outside of the electives that I've done this year, have almost no experience in outpatient palliative care or really outpatient care in general. But I think that the people who are experts in those fields can certainly use all of these same recommendations and just kind of tailor them to their own needs. And I think that all of the same benefits would be realized in those practice settings.
Hi, thank you for an amazing presentation. So happy for you. I have two questions. One is a question about any thoughts that you have for the bedside nurse in terms of ways that they can be advocating for themselves and as a group in the settings that they're working on, maybe perhaps based on some of the experience that you've had. Mm-hmm. And then also I'm curious, as a person that has gone from being a nurse and now has moved to being a palliative care consultant, and somewhere in there has also made the transition to practicing as a nurse practitioner, I'm kind of curious about what you think you have kind of brought this interprofessional team as a nurse practitioner that you kind of carried with you and kind of taught the larger interprofessional team about?
Mm-hmm. So to your first question, I would say, coming from a place of curiosity, I talked a little bit about the friction that nurses can feel and really kind of the concern that they can feel for even sharing their thoughts on what's going on with patient care, because physicians are really the drivers of that care. They're ordering that care most of the time. I think that coming from a place of curiosity and just trying to understand what physicians are ordering, why they're making the decisions that they are. If you're asking just for your own understanding rather than coming from a place of frustration or presenting your concerns as, it's a very different frame to say, can you explain to me why you're making this decision? I would maybe have thought that this would be a better option, as opposed to, I think what you're doing is wrong. I think that we're harming the patient, because that puts everyone's back up. And I think that it's just like a roadblock to communication before you've even gotten started. And obviously the cultural shifts that I was talking about can support that. To your second question, I would say, I think that what I brought to this fellowship is really probably not dissimilar to what people from all of the disciplines brought to this fellowship. My experiences are just different than the physician's experiences. I had no idea what a palliative care social worker or a palliative care pharmacist did before I came into this fellowship year. And so I think that we've all just kind of served to like pull back that curtain so that we can see a little bit of what goes on in the day-to-day practice of these other clinicians. And realize that even though our training and our disciplines are sometimes very, very different, we're all trying to provide the same support, and we just have different tools to do it, or maybe different thought processes.
Thanks. Thank you.
Mm-hmm.
All right, Sam, thank you so much.
Thank you for coming.